Hello and welcome to the first Hospice of Central Ohio Listen and Learn podcast. These podcasts are developed as an additional resource for our volunteer team members as well as the community at large to help us all stay current with information related to end-of-life care. To kick off this new learning format, we've invited Carrie Hamilton, President and CEO of Hospice of Central Ohio, to walk us through some of the basics of end-of-life care, including the Medicare minimum, our mission, vision, and values, and how these all work together to support our patients and families at this most tender and poignant time in their lives. A little background about Carrie. He's been at the helm of Hospice of Central Ohio since late summer of 2009. He began his healthcare career in the 80s when he worked as a teaching assistant and nurse aide while studying social sciences at Shawnee State University. He then joined the U.S. Army and Army Reserves and completed his nursing training before returning to Ohio and working as a nurse in a variety of roles. Then he graduated from Mount Vernon Nazarene University with a degree in business administration. He also worked as an administrator in North Central Ohio for American Nursing Care in the late 90s and began his hospice service at VistaCare as a regional director for Ohio, Pennsylvania, and Massachusetts. Carrie also served as vice president at Hospice of Dayton for nearly 5 years before coming to Hospice of Central Ohio. So Carrie, thank you for bringing all that experience with you to us. Welcome. Good to have you.
Oh, it's my pleasure to be here, and thank you for that glowing review. Thanks.
I'm just reading the facts.
Yeah.
Just reading the facts.
You made them sound very good, though.
That's
Nicely
my
done.
job. That's my job. Well, let's start with the basics here. What is hospice? How is Medicare involved? What's the vision for end-of-life care as we look through the hospice lens? If you could talk about that.
You know, it's interesting. Hospice began many, many years ago. They tie it all the way back even to the Crusades, back to the time of, frankly, they had very little medical care, and even a minor wound would eventually fester and cause the end of your life. And so what would happen is they developed homesteads along the way, and people would gather there and wait to die. And it was a place, frankly, of solace, where, you know, the trials and tribulations of being at war and traveling were made easier. And so that's really the first concept we were able to find in history of really the hospice idea. Then we found Dame Cicely Saunders came along and was a real driver behind understanding dignity at the time of death, and focused a lot on helping people to find their way and to find comfort at the end of life, because quite often what we find is that the current medical expectation is focused so much on cure that often we can forget about the human being who's engaged in this process. And we think about that, you know, we often joke that, you know, there are two definitives, and it's death and taxes. And, you know, the reality is that everyone experiences this. Every family, every individual, no matter how rich, how poor, no matter how hard you try, you know, eating all your vegetables is not going to get you out of this. So, you know, the reality is that looking at end-of-life care, we have seen a transition. From the late 70s, when hospice came to the United States, it was a ground swell. It was all about grassroots. Everyone was a volunteer. And it was a drive to help the medical community understand that a patient who is dying in the ER should not be pushed out into the hallway to make room for a patient that needs current treatment, and no other expectation given to that patient, because that sort of thing happened. There's some terrible stories we hear about events that happened, and frankly, quite often we would find that patients who were in the ICU, children couldn't go see them, and so they would be there for weeks and then pass away, and no one got to be with them. So finding a way to provide comfort and support was really a cultural shift. Hospice developed, frankly, a strong support movement. And what we found is that Medicare came together with these activists, these people who really had a drive. And what we found a lot of times, it was the same nurses and doctors that were providing the care that were committed to improving this end-of-life care that were driving it. And so they got together with Medicare and said, how can we do this for everyone? How do we make it more available? So in the late 70s, they created this philanthropic movement. In the early 80s, it developed into a Medicare benefit. It was a demonstration project for a couple of years, and then was finally formalized in the mid to late 80s. Medicare established that it was a 6-month benefit. it was defined as someone who has a life expectancy of 6 months or less. Now, interestingly enough, is a relatively arbitrary number. You know, when they defined that, it was based on that they knew how much money they had, and they knew about how many patients they needed to take care of to have a statistically significant outcome. And so they divided it up and came up with 6 months. No one, and I do personally know several of the people that were on the committee that worked with Medicare to actually write this, none of them ever considered for a moment that the 6 month expectation would become a rule.
Huh.
And so it was interesting how that happened, right? And I'll come back to that. It's a very important
Okay.
aspect of that.
Please
There's a
do.
reason that.
Please do.
So the dynamics of it are that's how the Medicare hospice benefit began. And it was actually fairly slow to engage. Although there was reimbursement involved, what we found was that a lot of people were very hesitant to even talk about death and dying. And there was a big push at that point to really try to get the mainstream to understand that, you know, because it is going to happen to all of us, there are benefits to talking about what's going to happen. And it took time, energy. It wasn't until the late 80s, early 90s that it really started to catch on a little bit. And even all the way up until the late 90s, it was still, you know, a fairly obscure service. A lot of people heard about it, and most of the people who were involved in it appreciated it. You know, they were excited to be able to talk about how helpful it was, and once they got engaged. It wasn't until really around 2000, 2001 that a couple of organizations really took on the mantle of spreading the word and began to become a more national drive. Because until then, it had really been lots of very small, local organizations that serve individual counties. You know, we had some areas that had very strong organizations, but then there were lots of other areas that had no hospice available. And so as they pushed forward, the thing that we came across, or that they came across, was that the idea of talking about death and dying was frightening.
Right.
So people were scared. And you know, when you walk up to somebody, especially somebody who is faced with their own mortality, and say, let's talk about your death. You know, no.
Right.
You know, I want to live. I'm going to do everything I can to live. I don't want to talk about that. And so what they did was they recognized that they had to change the understanding. They had to change the viewpoint of where hospice came from. Not that they were going to change what hospice was necessarily, but they needed to come at it from a new angle to make it a more palatable discussion. So they approached it from the standpoint of hospice isn't about dying. Hospice is about living. It's about living as well as you possibly can with whatever time you have left. It's also about the people that you leave behind and helping them to live as well as they can. And frankly, being able to resolve the issues that you may need to in order for them and for you to be able to leave in a good way. And so that change really propelled hospice. Since 2000, lots of things have come about. But really, between 2000 and 2005, hospice grew tremendously. You know, while it sounds like a big number, hospice was only about $2 billion a year in 2000. Now, when you think about nationally, the hundreds of thousands of people getting service, $2 billion is not much money. Just to give an image of what $2 billion was to the Medicare budget, if you looked at single hospital systems, many of them were over $2 billion.
Right.
So in one city, one hospital system was over $2 billion. There was only $2 billion spent on hospice the entire country for the entire year. So when you're like, wow, it really wasn't very. Now here's the thing: between 2000 and 2005, that number went from $2 billion to almost $10 billion. And then from 2005 to 2010 to $13 billion, $14 billion, $15 billion, and it keeps going. So the dynamics of that are really interesting, right? So we went from a fairly obscure 6-month end-of-life benefit that really was very needed to, frankly, being available where now the entire country, nearly half the people who need hospice get hospice, which is fantastic in many ways.
Right, right.
Fortunately, there's some drawbacks to that.
Mm-hmm.
There's some real complications. Unfortunately, part of the difficulty that we run into with that is that Medicare itself is always challenged with the fact that when you attach money to anything, there are people who are going to abuse it and be bad players. And so we've been up against that even in the hospice industry. Mm-hmm. We have some folks who got into the business side of hospice purely for the sake of making a profit and have bastardized some of the systems and taken advantage of it. Medicare is working very hard to clean that up. On the flip side, one of the things that really drove this forward was that around 2005, there was a company that is a for-profit organization that had grown very large that went public and is now a publicly traded company. You can buy and sell stock on some hospice companies now. And so being a publicly traded company really gave them a lot of impetus to grow. And that's what drove that forward. Unfortunately, I wish I could tell you that it was the heart of hospice that made it grow into a $13 or $14 billion organization. But really it comes down to that it was the money that drove it. Now the good news is there are many of us who understand the heart of hospice. I did work for a number of years in a national for-profit organization, and they had a good heart. They were a good company, and the guy who founded it was a good man, and we did lots of good things. Unfortunately, what happened was they did go public. He retired, and they brought in a bunch of Ivy League high-end business folks, and their intent, as they said in their SEC statement, was to increase shareholder wealth and maximize dividends and returns.
So, Carrie, everything that you just said is new maybe to some of our listeners. I'm wondering if you could go into a little bit more detail about the differences between not-for-profit and for-profit hospices, and maybe dispel some of the mythology that in the United States hospice is a national organization with a lot of little chapters. Help us out and understand that a little better.
Sure. Well, I think it's important to understand, our mission, why we exist, is to provide every family a compassionate and personalized end-of-life experience, and want to exceed their expectations. That is a very different mission than, frankly, increasing shareholder wealth, which is what quite often for the publicly traded companies happens. It's why they're there. It doesn't make them bad people, and they will tell you that we have to give great care in order to do that.
Right.
But the reality is it is a nuance that is very important. For us, we often find ourselves focused on, quality of care. We find ourselves providing services that really don't have the ROI. And me, as a CEO, I can tell you, I am faced with ROI decisions every day. In the for-profit world, the return on investment is simple. I either make money or I don't make money. In my world, the return on investment is often what is the benefit to the community? What are the outcomes to our society? What are the things that we do that will improve our patients' lives? And then, how do I pay for it?
Right.
So that nuance is incredibly different between the for-profit world and the not-for. And I will tell you, I've worked in both. The thing for me is that when I worked in the for-profit world, we were very efficient, very effective in many ways. The problem is that we quite often made decisions that did not always support the best outcome for the patient, but supported the best outcome for the organization or our bottom line. And we often worked very hard to stay away from indigent and charity patients unless, and unfortunately I've been in the room with boards when they've had this conversation, we can do that, but how many more patients will we get, and can it increase our margin if we do it? That question is always there. And so, it doesn't make them bad, it just is a reality to it. Now, I'm not saying that we don't think about money. Then I worked on the not-for-profit side where, frankly, the heart was everything. And unfortunately, the reality is all we found is that there was no focus on efficiency or effectiveness, and so there was waste, and there was bureaucracy, and there was a failure to, understand that what's best for the patient sometimes requires that we make good, conscious financial decisions. So my goal in coming here, some odd years, 6-7 odd years ago, I had to think for a minute, was to take the efficiency and effectiveness that I saw and frankly worked within in the for-profit world, and combine it with the heart and dedication and patient-centered focus that I found in the not-for-profit world, so that we could create a hybrid that wasn't drowned in the bureaucracy and the waste that we often see in nonprofit organizations, and also remember to keep the heart in the efficiency and effectiveness we do, and that's been my goal since being here. Our core values and really why we want people to choose Hospice of Central Ohio is that we want to, we embrace this dynamic approach to end-of-life care. It's not just about coming in and giving some nursing visits and having a social worker come out and visit you. We want it to be truly an experience. We want to envelop the patient in a warm blanket of nursing, social services, aid services, physician support, crisis care support, and aids that are available when you need them, not just necessarily when it's convenient for the company. Social workers who are engaged in helping you to work through issues. Chaplains that are not only there to provide the occasional Bible study or reading, but truly be able to help you work through your personal needs related to spiritual assessment. And so putting that together, and to do that, that really takes an all-encompassing approach. The other piece is that we want to provide all eligible patients access to end-of-life care. We talked about early on that 6-month window and the fact that, hospice started, in the 70s and very few people got it, and then in the 80s Medicare got involved. And the reality is that as we tie that in, that reaching all eligible patients really requires a change in how we think about end-of-life care. And right now, we're going through that with Medicare, and we're going through it with CMS. Even within our state, with MyCare Ohio, there are a lot of changes happening. Those changes are really forcing us to step back and think about, is the 6-month window the right window?
Right.
How does palliative care, which all hospice is palliative, but not all palliative care is hospice. Palliative care is specifically about symptom management and providing care and comfort and recognizing that there is no cure.
Coming up, we'll learn about and hear about the personal side of making an end-of-life care decision. Stay with us. Reassurance, understanding, a smile. Someone needs what you've got. For so many of the patients and families in our care at Hospice of Central Ohio, these simple gifts can make the difference between a day spent worrying or a day spent feeling nurtured and relieved. We invite you to consider giving these gifts of compassion to the people we serve by becoming a volunteer member of our team. To learn more about the opportunities that await you, please contact Hospice of Central Ohio Volunteer Services at 740-788-1404 or by visiting the volunteers page on our website at www.hospiceofcentralohio.org. Reassurance, understanding, a smile. Someone needs what you've got. We've invited Carrie Hamilton, President and CEO of Hospice of Central Ohio, to walk us through some of the basics of end-of-life care, including the Medicare minimum, our mission, vision, and values, and how these all work together to support our patients and families at this most tender and poignant time in their lives.
So I recently had a conversation with a cardiologist, and in that conversation he pointed out to me that the majority of the conditions that he treats are not curable. When you think about heart disease,
right,
atherosclerosis, you have your congestive heart failure, and all these conditions, they're not going to go away. Now, you manage them, you mitigate the outcomes, but unless you replace someone's heart, it's not a condition that you can cure. And it's interesting how, when you think about it, palliative care simply identifies that there's not a cure and that you're going to treat the symptoms of. So there's a natural tie-in there somewhere of where palliative care really could begin much earlier in the process. There was a gentleman that I spoke with. He was from Rome, and in that conversation he identified that quite often they have a palliative conversation with folks at the point that they receive a cardiac diagnosis of congestive heart failure or chronic obstructive pulmonary disease. That they begin the conversation, and when we talk about palliative care and the impact of that, one of the things that we often forget is that it's really about goals of care. You know, when you think about it, if somebody comes to you and says, well, you have congestive heart failure. Well, what do you want by going to the doctor? What would you like to have? Well, I want to be better. Well, what's better? You got to establish those goals, because what better will not be is without congestive heart failure, because that can't be done. You're always going to have chronic obstructive pulmonary disease. And what happens so often is that we get caught up in these expectations that, you know, by talking about the goals of your care or talking about palliative care, that it means talking about the death process or what happens at the time of death. The reality is having conversations about palliation of symptoms really could begin at a much earlier phase and be handled in a very different way. And frankly, whenever you start talking about those things, you find that knowing what your end game is makes it much easier to be able to improve your quality of life. Hospice has been relegated to the last 6 months and has become focused upon about really being about dying. Now, frankly, we're all dying. It is what it is. Every day we're one step closer. So the question isn't, is it going to happen, but should we talk about it, and when do we talk about it, and how can we make it an experience that is, frankly, as positive as could be. And so that's where we as an organization think it's important to affirm self-determination. You know, when you start talking about what does it mean to determine what you want. One of the worst scenarios I have seen is the one where individuals end up on a ventilator, brain dead, with broken ribs, in ICU, with no quality, and living for weeks. Or worse yet, they survive to even be discharged from ICU and go to a long-term acute facility and lie there for months while the family sits waiting. Their loved one left the day they had the event, but they are maintaining their body, and they can't figure out what to do and how to handle it. I know for me, giving a clear picture of what I want to have happen is important. And I think most people, if they can get past that initial discussion, would want to do that. For us, it's important to give that opportunity and to be witnesses to that in a way that is supportive. Right now, there's a change in Medicare. The change that is occurring is this. They're recognizing that palliative conversations need to be had sooner. Now, we all know that, unfortunately, care seems to follow money. Medicare put money behind the palliative notion finally. You can now, physicians can bill for those visits. That will encourage those to happen. At the same time, we're looking at how hospice is structured. Is 6 months the right window? Is the level of service that we're providing the right amount? And so all of these discussions are happening all across the country. And frankly, I think it's an exciting time to be part of end-of-life care. And so as an organization that is, frankly, focused on recognizing the sacredness of leaving and honoring the feelings of loss, you know, we need to be able to position ourselves in a way that we are innovative, able to understand the shifting dynamics within the Medicare world, but also connected to the heart of what our community and society need. Because we started hospice because it was needed. There was a gap. Well, that gap has shifted. You know, now in medical school, they teach doctors how to talk to a patient who's dying. They teach them the psychology and the social dynamics involved with that. They didn't used to. So now that they're doing that, we as an end-of-life provider are looking at how can we broaden our expectation in order to be able to meet the new needs. and to innovate and grow as we go forward.
So, Carrie, what advice would you give to someone considering end-of-life care for themselves or for someone they love?
You know, it's interesting when we think about these choices, and you know, it's brings to mind my own family struggles with these, because you know, we all have this. And the interesting piece is that you know, I've worked in hospice now 16 years. I've been in healthcare for nearly almost 30, going on soon. And the reality is that my family, we talk about hospice and we talk about care, and I tell stories of things that happen and all this. And so my family's very aware of hospice. My uncle was in need of hospice services, and I can tell you that it was a struggle in getting my own family to engage. And, you know, I would share with them the benefits of hospice. And we would talk about it, and they're like, well, when we need it, when we're ready, when we need it. And the interesting piece of it is that I missed a key element. And you see, I was focusing on the fact that we could provide care and support at the time of death, helping them to have understood, looking backwards, that there are so many things that need and can be done beyond just that physical support. It is emotional, psychological, it is spiritual. It is tying all those pieces together and establishing those connections so that when the time does come, they're ready. And I think that the most important thing I would say to someone is to don't focus on the time of death and the act of dying. Focus on what can be done to help their lives be better now. I had a telephone call, and I'll be honest with you, I don't get many of these types of calls. It was a phone call out of the blue. A family member wanted to talk to the CEO. Usually when that happens, it's not a good thing. You know, somebody is unhappy, or there's been a problem or something going on, or somebody needs something somewhere. And so I took the call, and I was a little bit trepidatious. I mean, you know, nervous about, oh my gosh, I hope something bad didn't happen. And turns out she was calling because she felt compelled to call and tell me how much hospice had done for her. She was an actual patient and had only a couple of months to live, and felt compelled to make sure that someone knew just how much of an impact hospice had had for her. And that she had not realized, when hospice had engaged, all of the different things that they would bring to the table. And she went through the list of, you know, the spiritual support, the social support, the individual care provided by the aides and crisis care and so on and so forth. And the most important thing that I took away from that call was that not once did she mention, nor did we discuss the fact that she has a terminal diagnosis. She was focused very much on how much time, support, personal strength, emotional strength she had been able to gain from having that extra support. And so when we talk about what would someone say, it really does come down to that having that extra help and being willing to let those people come into your life, letting the hospice team wrap you in that warm blanket of care. Not only will it help you as death nears, it will help you to make more of the time you have now. It will help you to be able to enjoy that time. And frankly, the emotional support of knowing that there is someone for your loved ones to talk to. There is someone for them to lean on. And quite frankly, one of the biggest things that I saw with my own family when I had my grandmother who had been on services and finally did get hospice at the very end for a very short period of time. When they engaged, frankly, the biggest impact was not on my grandmother. It was on my aunt who she was living with and her husband and some of the other family members. Because suddenly the weight lifted off of them, that someone else was there who knew what to do. And so, using those experiences, has helped me to frame the way that we do things here. And to understand that we really do need to be able to communicate with people, that coming sooner. I have never, in almost 30 years of healthcare experience, had anyone tell me I came to hospice too soon. Almost everyone has been, I wish I would have known. I wish I would have started sooner. And it's interesting because you have one family member who gets hospice, the next one tends to get it considerably longer because the fear is gone. And I think it's an important aspect of that.
Mm-hmm.
We do recognize that every patient needs to have some determination in what the end of life will look like for them. But frankly, it isn't just the patient. It's the whole family. They all need to be involved in that discussion. The most beautiful moments in hospice are not the ones where we have someone who passes quietly in their sleep. The most beautiful moments are the ones where the family is together. The brother who has been disconnected for 9 years is there. The siblings, children and grandchildren are there. They're holding hands. Yes, there are tears, but it is a bond. I get chills when I think about it because we went through this with my sister-in-law who died at a young age in her early 40s from breast cancer, and we were all there in that way. That moment was priceless. It was a moment that defined, I think, how we deal as a family with death and dying and brought us all closer. And so when I think about those things, that is the kind of experience that we're trying to build. It doesn't always happen that way. Sometimes it's complicated. But the reality is that we want everyone to be able to decide how they want to have it happen. But most importantly, we want those people that are left to have support. Our grief and bereavement programs are so important. And frankly, the spiritual support that they get along the way just ties right into that. We have groups and so many different things. Maria Johnson is our leader of our bereavement program, and frankly, I believe is going to do our next segment, and I think you'll find that she is going to share some amazing things and some great stories and be able to explain a little bit about what we do for those folks that are left behind.
Carrie, you've given us a lot to think about today. Thank you for the gift of your time and your knowledge. And thank you, listeners, for joining us in this new learning format. We encourage you to please visit our website often for additional resources and learning opportunities at www.hospiceofcentralohio.org. Thank you.